Welcome to What Makes Up Your Mind? Updates from the frontiers of neuroscience, well-being, and mental health from the Department of Psychiatry and Behavioral Sciences at Stanford University's School of Medicine. This is your invitation to meet the faculty dedicated to understanding our most complex organ, committed to curing mental illness, and inspired to help create a healthier, thriving world. Thank you for checking in on another episode of What Makes Up Your Mind, and one that continues our mini-series on Stanford Psychiatry's special initiative of the chair, AI for Mental Health. I'm Jane McMillan. We have the pleasure of hearing this time from Dr. Ehsan Adeli, who's working with this powerful technology to create more accurate screenings for mental illnesses and cognitive decline, resulting in faster diagnoses with earlier interventions and more effective treatments. Dr. Adeli is a Stanford Associate Professor of Psychiatry and Computer Science. Along with co-directing the AI for Mental Health initiative, he's the director of the Stanford Translational Artificial Intelligence in Medicine and Mental Health Lab, and he shares leadership of Stanford's AGILE Consortium, and that stands for Advancing Technology for Frailty and Longevity. Dr. Adeli has some fascinating studies underway in real-life situations, and I guarantee you're going to be captured by his vision and his enthusiasm for the potential of AI in mental well-being. Dr. Adeli, very happy to have you. Thank you for your time.
Thank you very much for having me. It's great talking about these topics that are very close to my heart.
You know, I'd like to kind of put you on the spot at the very beginning and say, if you and I had met at a party and I said, oh, what do you do? And you were to tell me you were working on AI interventions for better mental health treatment outcomes, I would say, gosh, that's a huge topic. What drives you in this field? What excites you about this? Why do you think this is important?
Very good question and very interesting question, because I am coming from a purely technical background with a PhD in computer science and AI. But what I cared about was to actually see the impact and the outcome of my work and my research, not only into some technical and AI papers, but also to be able to translate those into some human impact. And in order to do that, after my PhD, I started research and work in neuroscience, computational neuroscience, and got into the space of brain and mental health for applications related to sometimes aging and aging research, as well as some mental health research. So creating and having an impact is one of the main reasons that I'm actually here. And when I do talk with folks in my research studies, and I do see their perspective of how AI and these new technologies is changing their lives and changing their everyday work and interaction with AI, and then my research being able to somehow impact improving the qualities of life, it excites me a lot. That's what is driving my research right now. The other thing is, given all of the advances in AI in the past fields, I think what we are lagging behind right now is really and actually translating the use of AI models into some clinical and medical applications. What I'm seeing right now is, in most cases, the researchers, what they often do in the clinical space, they are taking AI models off the shelf and use them for a specific, say, clinical application, which is very good. We need this type of research. We need to evaluate the models off the shelf. But what drives my research is to close a gap between basically what the state of the current AI models are and what we need on the clinical side, because models off the shelf will give us some baselines, yes, but that could be definitely improved to bring AI models into real application, into real impact. And that's what we are doing right now in my research group. I know this was a lengthy explanation or response to your question, but there are quite a few different angles and components that is driving my interest and my research. One more thing that I want to maybe briefly talk about, and I just remembered that that's one of the main reasons that I'm still in academia, is working with amazing students and talents and colleagues here, very cross-disciplinary and interdisciplinary work. And I enjoy working with all of those young talents. They often bring new and novel ideas to the table, and this really excites me.
Well, it was a perfect answer. And I asked it because I've heard you in other settings. And to me, the excitement in your voice is palpable. And it is here today as we're talking, which I think really translates to those listening as patients or as potential patients who are thinking, well, I'm hearing about all this creepy AI interaction on social media and videos and off-the-shelf products that are posing as mental health tools. And so the excitement from somebody as learned as you and devoting your life to this, I think, lends us excitement, but also confidence. So I'd like to talk a little bit more about specifically what you're doing with these large language models in this setting of mental health and real world outcomes. And just as a quick recap, these large language models, correct me if I'm wrong, these are massive AI systems built and they're trained for processing, understanding, and generating human language. There's a reasoning factor that these LLMs possess. Did I get that right in a very basic?
Absolutely. Yes. I want to add to that what we often refer to everyday conversations as AI. Notions that we hear about in TV and news is mostly referring to LLMs. And actually, AI is beyond what LLMs are. And linguistic intelligence is one of the aspects and contributions that AI could actually create. But you're right, LLMs, large language models, and maybe multimodal large language models these days are everywhere. Even now, I would say mediate interactions between patients and clinicians. I myself, as a patient, whenever I have to visit a doctor for any condition, I always use AI. Or we used to be doing like WebMD and Google research before our clinic visits, but now everybody asks questions from AI. And this becomes kind of important in the mental health space itself, because many people feel more comfortable talking to LLMs and, say, large frontier AI models, because they think, and I want to stress that on the thinking part, they think that these systems are always available, non-judgmental. And because of that, it allows the patients to express thoughts and emotions without fear of stigma or social consequences. And often, like, conversations can feel, again, for them, private and low pressure, which lowers barriers to disclosure, and particularly on sensitive topics. And these LLMs provide immediate responses, structured reflections. They can provide support, creating, again, a sense of being heard and understood that is difficult to achieve in time-limited human interaction. So because of all these, there are so many use cases of LLMs. They are increasingly being used in mental health support. But I just want to warn everyone that none of these LLM models have proper evaluations in the clinical space, the clinically critical dimensions, especially when it comes to psychiatry and psychotherapy and so on.
But the LLMs you're working on differ in what's on the shelf out in the public.
Yes.
One of the several things that you're working on is LLMs in mental health diagnostic work, making these LLMs faster, more accurate than the usual pre-appointment questioning, maybe from a technician, maybe on a piece of paper. Talk about what you are drilling down on and how these things can reason and with better accuracy help a doctor, a clinician with a diagnosis.
Absolutely. In my research, in our research, we are looking into two different but interrelated directions. One of those, as you said, was mostly diagnosis, trying to make use of not just LLMs, AI systems in general, to see if we could diagnose some of the mental health traits with interactions with individuals. Like, for example, we recorded the conversation, video recorded and audio recorded a conversation with patients in a mental health clinic visit before the actual visit with the clinician, and used a multimodal AI model to predict the scores for depression and anxiety. With this AI model, we were able to obtain very good results by looking at the content of what they said, to the tone in their voice, as well as their facial expressions and gestures and so on while answering those questions. But then, because LLM models have been so advanced and they are trained on vast amounts of data, we observed that the language alone is actually able to predict these clinical scores of depression and anxiety in a very accurate manner, up to 90%, 90 plus percent accuracy. This is the component that is on diagnosis. But the second area, if you remember, I said two major areas. One is mostly diagnosis, but the second area is we are working on a series of projects, and we are establishing a framework to evaluate and improve therapy chatbots. So chatbots that can do, say, cognitive behavioral therapy, CBT. Many of the current chatbots do claim that they are doing such a thing, such a work, but we've shown otherwise.
I'm sorry, may I stop? And just before we get to that,
Absolutely.
You were talking about the accuracy rate in the diagnostics, around 90%. How does that compare without it, this AI component?
So we calculate these accuracies against the clinical gold standards that we have. Again, these are questionnaires. There are some levels of subjectivity to the measures that we get from these, and there is argument around how reliable and objective these types of questionnaires are, especially in the mental health space. So that is the limitation here. So this is how we've calculated the accuracy. And in clinical environments, it's the same type of measure. They use also these questionnaires for calculating accuracy of human level measurements. But in this context, I would say most probably the human judgments and human interactions can provide even better accuracies. But the problem is that most of the individuals go undiagnosed or underdiagnosed. Many people do not visit a clinician for mental health treatments. And on the other hand, clinicians are so overburdened with work that they have limited time, and I think there is data of more than 60% of cases they are underdiagnosed. And what we've shown with this AI system is if we can run this conversation, we can have this conversation with the individuals, autonomously we can create these risk scores for individuals. So the accuracy itself is one metric that the system is reliable as a precursor to an actual clinic visit, for example. See who needs the most help and actually make use of the clinician times in the best way possible, create more accessibility. And they can often be run on low-cost hardware, sometimes on tablets and some phone devices and so on. Because of that, I think that's the value that these types of models bring to the table, not the actual diagnosis itself. If a clinician has time to talk with the individuals for an hour, there is a good chance that they have a much better understanding of the diagnosis. These AI models can help create this accessibility if they are reliable enough in terms of diagnosis only. Was this answer related to what you had in mind.
Absolutely. And that takes us right back to where I interrupted you. Pardon me for doing that. But that's the reliability factor
Absolutely,
that
yes.
you were discussing in one of your projects called Therapy Gym. This is where you're
Yes.
testing LLM models and their accuracy.
Yes. Therapy gym. We call it therapy gym because it's a combination of different components that work in harmony with each other. So I'll talk a little bit about it. So yes, in this project, we are trying to improve, as I said, evaluate and also improve therapy chatbots along two major pillars for clinical science, fidelity and safety of conversations. So our research is exploring, as I said, CBT, clinical behavioral therapy, as a basis because it has been extensively researched and demonstrated to be effective for a variety of mental health disorders and populations. So we built models that are operationalized through the CTRS, which stands for Cognitive Therapy Rating Scale. This is very well known and widely used as gold standard tool for assessing the competence of therapists delivering the cognitive behavioral therapy in therapy conversations. We adapted that into our automatic pipeline to measure those conversations that are being generated by LLMs are skillful and safe. So we collaborated with a few clinicians who were trained with CTRS and created a huge data set of therapy conversations. And we labeled those with CTRS skill and safety measures. This data set and all of these ratings, manual ratings by expert clinicians, were input to a model that we called a therapy judge, that through this rubric of CTRS skills and safety measures, this judge looks at each therapy conversation with the patient and turns that into a few scores of how good and how skillful, how safe this conversation is. It is important because this is one of the few first steps for evaluating these AI models in the mental health space, in clinical usability. All of these that I'm telling you about is automatic systems that they can judge the outputs of LLMs. And ultimately, the last step that we've done, which completes this, this gene, is we use this judge to improve any LLM that we can actually fine-tune. Fine-tuning is a process in AI that you take a model that is already built and trained on larger scale data sets. Like, for example, some of these frontier company product AI models, they are closed source. We cannot fine-tune them. We cannot change anything in them. But there are so many others that are open source models, and we can change their behavior. We call it like fine-tune those models. And with this judge, now we can go back and improve those LLMs and give them the knowledge of safety and skillfulness with respect to CBT, cognitive behavioral therapy. And that's actually what we've done in this project and this work. We use something called reinforcement learning, where we use the judge that we created as a reward function that goes back, gives back to the LLM model and tells the model, for these responses, I give you more rewards, but I want to penalize you for this response because if this was, for example, not safe. Do not use it anymore in the future conversations. So basically, through this reinforcement learning framework, we can fine-tune and rebuild and improve the current LLM models. And again, that's why we call this therapy gym, because it's as if a gym that is all of these automated tools are working together to improve LLMs with respect to psychotherapy.
So cardio, weightlifting, muscle memory, that's what the reference to the therapy gym.
Absolutely.
That brings me to the human part of it, because when you were describing this, especially with cognitive behavioral therapy as the model you're looking to refine in an LLM, there's the human element. You're taking information from qualified therapists and clinicians and the process, and that's part of this, what goes into this judge.
Absolutely.
So it's not a replacement necessarily for human interaction. This is an enhanced tool.
Absolutely. All of this is mediated by humans in terms of evaluating the outputs. But one of the major outcomes of this work and this research that I'm seeing, and I think it's, from my perspective, very valuable, is we can now evaluate the claims of many of these models. They claim to be skillful and safe, trained or built for mental health wellness. But with these steps that we've created and this judge model and so on, we are now able to evaluate many of those quantitatively and come up with some scores, something that we didn't have before. So basically, we can benchmark all of these models. And beyond that, what we've shown in this work is such a system can be also used for improving the LLMs for therapy, psychotherapy, but a human component and human element is often what is really needed for the improved patient outcomes. With that, I think all of these tools and models should probably be paired with or prescribed by clinicians and not individually used for clinical improvement on those individuals that do require attention. But yes, there is a lot of human components involved, and this system that we've built is a human in the loop system.
As long as we're talking about humans, one of the terms that has come up when I'm reading about your work is human-centered AI. Mm-hmm. You have so well told us how excited you are about how this work is going to positively impact the end user, which are patients for early diagnosis. And one of your passions is cognitive issues and catching cognitive decline early. So could we move on to talking about your work on ambient AI and passive sensing, and what do these things mean, and how are you using them? You're testing, and I'm going to prompt you with the Yuma, Arizona project.
Thank you. Yeah, this is great. Again, another topic that I've been working on for now, I think 7-8 years, and finally we are seeing some results, some actual results and human impact. Yes, this is around the topic of ambient intelligence. This may be a new term to many, maybe audience of this podcast. Ambient intelligence refers to an environment that is basically sensitive, adaptive, and responsive to the presence and actions of individuals through the use of a field of computing, which is called pervasive computing, that uses sensors and artificial intelligence and responds to human needs in that environment, whether it's a workplace, at home, or we've even tested this in the hospital. So such a system enables systems to seamlessly integrate into everyday life, providing personalized experience and improving decision-making without requiring active user involvement. So the goal of ambient intelligence is to create intelligent environments that enhance the quality of life, increase convenience, and support users in daily activities, daily behaviors, and so on. We've been developing this ambient intelligence for healthcare applications in hospital spaces and in home spaces. At the heart of my research have been systems that are non-intrusive sensors, like, for example, passive cameras, audio, and environmental inputs that recognize everyday behaviors. And our algorithms learn what's normal for each individual, what is their baseline behavior, and so on, and then use that to detect subtle early disruptions in function. We know that early disruptions in function and behavior are early indicators of many different issues. One of those is neurodegenerative and cognitive decline. what is unique and main benefit of such a system is the ability to understand human activities, behaviors, and sometimes it's actually micro gestures, because when we are talking about depression, anxiety, and so on, sometimes it's their micro gestures, not necessarily just movement, which this type of information, this type of data can be only captured directly from images and videos of individuals. You can't get it with wearable devices or other sensing modalities, because wearable devices often give you some physiological signal, some movement signal, and so on. But they are not grounded with mental health and cognitive health aspects. So they're mostly physical measurements. With this technology, we tested that first in the Stanford Hospital. If we can understand activities and behaviors, let's look at the bedside activities and behaviors in the hospitals, because that's where we want to minimize error rates, increase the quality of healthcare delivery, and so on. And we created this transformative shift in hospital safety and auto documentation, I would say, using these ambient AI models. We published this work in 2025 in the New England Journal of Medicine AI, where we called that system a clinical behavioral atlas. So this is ambient intelligence and ambient AI and how we used it for one application in the hospital. But related to the cognitive decline, yes, we implemented these technologies for home environments. We started with Yuma, Arizona, amazing research participants there. We had in a senior living facility. Then we opened up nationwide, and it's an ongoing project. It could not only be used for senior care or even hospital at home applications, but we explored methods to understand mental health and psychiatric symptoms early on.
May I clarify? So when we're talking about the passive sensing and the vision tools, we're talking about microphones and cameras.
Right, yes.
There's this incredible excitement about what it can do, having those tools be able to observe and pick up things daily that wouldn't be picked up once every 6 months in a clinician's office.
Exactly.
And the progression, especially of cognitive decline. But we're also still talking about an observation tool, as well as the AI processing tool of how to utilize that information.
Absolutely.
As a non-scientist and as a consumer of what this will be able to offer me, I'm excited as a patient. But alarm bells kind of go off with privacy issues.
Yes.
Who gets to use it? Would the government get to use this information? Would insurance companies get to use it? That should not be the initial concern as you're developing these fantastic tools, but eventually people are going to be asking this, and often societal rules about these things are far behind the technological advancements of them.
I couldn't agree more with you. We do have some solutions on this. We published a paper in the psychiatry department and then Department of Medicine a few years back on ethical and privacy concerns of ambient intelligence in healthcare spaces, healthcare domain, published in the Digital Lancet journal. The project was led by my colleague, Dr. Martinez Martin, and there we identified 6 different stages of building these models and proposed all of the solutions for safeguarding the data for each of the steps. The first few steps are building and developing and doing the research for these models, and we've been able to do this through building trust with our participants and collecting their data, because in the analysis stage, research team has to look at portions of the data to be able to build the algorithms themselves. On the privacy component, privacy side, I think what you're explaining is spot on, and we've been exploring what we call AI at the edge. So the idea is we build these algorithms. These algorithms summarize the activities and symptoms of individuals and only puts those symptoms, the markings of those symptoms and triggers and few occurrences over time, and records them in the patient's records, puts them in the clinician dashboard the same way if they visit the clinic every 6 months or once a year. The clinician has all of the symptom and information in numerical format explained to them, instead of the patient themselves having to fill out a questionnaire, and those questionnaires are subjective. Patients often they forget some of the behavioral changes. There is a stigma around some of these behavioral symptoms that people even do not report them. This system can summarize those, and only in numerical format, the data leaves the home. So AI at the edge is building the models and putting the models all run on a tiny device, on a tiny machine in individuals' homes without any data leaving the home, even leaving the sensor itself.
So no pictures, no audio.
That is correct, yes.
What comes out of it is what you're saying.
Exactly.
Just the numerical information for the clinician. And it would be under HIPAA rules like everything else.
Absolutely, yes, exactly. And I often refer to this system as building a vital signs monitor of behavior, because we do have vital signs monitor of heart rate, physical activity, and so on, but we don't have anything for behavior, which very well connects to mental health. And this system, this type of ambient AI and these types of sensing can create this vital signs monitor that we need for human behavior. It's very, very important. We looked at neuropsychiatric symptoms or NPS, mood disturbances, apathy, agitation, facial expressions, and some of these types of symptoms, which are among the earliest and sometimes most telling signals of cognitive decline in daily life, can serve as what we refer as markers or digital biomarkers, because now we are able to digitally quantify all of those. And that's the area, that's the research that we've been doing. And again, these are most telling with respect to any form of cognitive decline of neurodegeneration and brain health.
And who wouldn't want to, especially as treatments and interventions are emerging, who wouldn't want to jump on it as early as possible to preserve their brain health?
Absolutely.
None of this goes on in a vacuum. You've mentioned some of the collaborations. You're co-director of the AI for Mental Health initiative of the chair at Stanford. How do you see your work fitting into the larger area of AI mental health medicine? And as you'd like to help direct this Stanford initiative forward, what's next?
Yes, we have created this community. I often want to refer to AI for mental health as this community of AI researchers and those who care about the clinical application, the mental health applications, and individuals like myself that kind of stand in between understanding and building the AI algorithms and taking them, translating them all the way into the clinical use. And with that, I want to say that one of the major missions that we have at Stanford, and I think, to be honest, it's one of the few places that we can have such an ambition, is to really, as I explained from the beginning of this conversation with you, take the AI algorithms and build them, rebuild them for mental health applications instead of what we often see out there, many of these models being taken off the shelf, sometimes without the proper evaluations. This is what AI for mental health is right now facilitating. And for this, Stanford is a good place because we have a School of Medicine and Department of Psychiatry next door to the School of Engineering. And when we have a question around any of these AI tools and the clinical applications, policy and law, even sometimes entrepreneurship of building these tools and creating products out of them, we have colleagues that we can actually go and knock at their office door and start a conversation around policy, ethics, or whatever. So this is what excites me about AI for mental health within Stanford, initiated within the Department of Psychiatry, but this is a university level initiative with 7 schools within the Stanford University. This goes beyond my or any individual colleague's expertise, but creating this holistic view of how AI is impacting mental health and how its future should be formed by better evaluations, by better benchmarking different domains and applications, and then inform future policies in terms of how we should move forward with this. I'm hoping that this community, this group that we've created, can inform many of those.
Dr. Ehsan Adeli, I can't thank you enough for tackling, explaining this deep and complicated topic, your patience is incredible explaining it to me. I really appreciate it, and I'm sure our listeners do too. Thank you very much, and best of luck going forward.
Thank you very much. I appreciate all of the questions and thoughtful conversation.
Dr. Ehsan Adeli, Associate Professor of Psychiatry and Computer Science. He co-directs the AI for Mental Health Initiative and directs the Stanford Translational Artificial Intelligence in Medicine and Mental Health Lab. And he's also a leader in Stanford's AGILE Consortium for advancing technology for frailty and longevity. This is meticulous work, as you heard, with safety and efficacy front of mind. So Dr. Adeli says, yes, it will be a few years before some of these tools are widely in practice, but they are on their way. Follow links to Dr. Adeli's work in our program notes. We only scratch the surface. In fact, you can hear more about the vast Stanford community of departments, researchers, and labs across medical AI specialties by listening to the other episodes in our AI for Mental Health series on What Makes Up Your Mind. I'm Jane McMillan. You've been listening to What Makes Up Your Mind? Updates from the frontiers of neuroscience, well-being, and mental health from the experts in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine. For more information on this program and all of our transformational work, visit us at med.stanford.edu/psychiatry. What Makes Up Your Mind? Updates from the frontiers of neuroscience, well-being, and mental health is a production of the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine, a copyright of the Board of Trustees of Stanford University.